Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of stridor and laryngomalacia for general pediatricians. Laryngomalacia is the most common cause of stridor in infants and one of the most frequent referrals to pediatric otolaryngology. We will walk through 10 carefully designed clinical scenarios covering the clinical presentation, physical examination findings, pathophysiology, investigations, severity classification, differential diagnosis, medical and surgical management, complications, and long-term prognosis. Let us begin. Question 1. Clinical presentation. A 4-week-old male infant presents with noisy breathing that began at 2 weeks of age. The mother notes the sound is high-pitched and occurs only when the baby is breathing in. He is feeding well and gaining weight appropriately. Which characteristic of this infant's stridor is most suggestive of laryngomalacia? Option A, presence of expiratory wheezing. Option B, improvement when the infant is crying. Option C, worsening when the infant is in the supine position. Option D, acute onset following a viral prodrome. The correct answer is option C, worsening when the infant is in the supine position. Laryngomalacia typically presents with inspiratory stridor that worsens with activity, feeding, or supine positioning. When the infant lies flat on the back, gravity pulls the tongue and supraglottic structures posteriorly, which narrows the airway and intensifies the stridor. Symptoms usually begin within the first 2 weeks of life and peak between 4 and 8 months of age. Most infants are described as happy wheezers, meaning they remain clinically stable, feed adequately, grow well, and have no significant respiratory distress, despite the noisy breathing. Question 2. Physical examination. During a physical examination of a 2-month-old with suspected laryngomalacia, you observe the infant's breathing patterns in different states. Which physical examination finding would most likely be observed in a typical case of laryngomalacia? Option A. Stridor that diminishes when the infant is placed prone. Option B. Prominent barking cough and hoarseness. Option C. Asymmetric chest rise and localized wheezing. Option D. Persistent stridor that remains unchanged during sleep. The correct answer is option A. Stridor that diminishes when the infant is placed prone. In the prone position, gravity pulls the floppy supraglottic structures forward and away from the airway lumen, which improves airway patency and reduces the stridor. Conversely, stridor typically increases with agitation, crying, or feeding because these states generate higher inspiratory negative pressure and pull the floppy tissues inward. A barking cough and hoarseness would suggest croup or vocal cord pathology, while asymmetric chest rise points to a lower airway problem, such as a foreign body. The physical examination should also assess for synchronous airway lesions, which coexist in approximately 20% of cases. Question 3. Pathophysiology. You are explaining the underlying cause of the floppy airway to a concerned parent of an infant with laryngomalacia. What is the primary pathophysiological mechanism responsible for the stridor in laryngomalacia? Option A. Subglottic narrowing due to mucosal edema. Option B. Fixed obstruction of the trachea by a vascular ring. Option C. Paralysis of the vocal cords in the paramedian position. Option D. Inward collapse of supraglottic structures during inspiration. The correct answer is option D. Inward collapse of supraglottic structures during inspiration. Laryngomalacia is caused by the inward collapse of the supraglottic tissues, specifically the epiglottis and the arytenoid cartilages, into the airway during inspiration. Common anatomical findings include an omega-shaped epiglottis and shortened aryepiglottic folds, which together produce the characteristic dynamic obstruction. The exact etiology is still debated, but likely involves delayed maturation of the laryngeal cartilages or altered neuromuscular tone in the laryngeal sensory motor system. This is a dynamic obstruction, meaning it occurs only during the negative pressure of inspiration, which explains why stridor is purely inspiratory. Question 4. Investigations. A 3-month-old infant has persistent, moderate stridor. You decide to refer the patient to a pediatric otolaryngologist for a definitive diagnosis. Which diagnostic procedure is considered the gold standard for confirming laryngomalacia? Option A, lateral neck X-ray, soft tissue view. Option B, high-resolution computed tomography scan of the chest. Option C, flexible fiber optic laryngoscopy. Option D, barium swallow study. The correct answer is option C, flexible fiber optic laryngoscopy. Flexible fiber optic laryngoscopy performed in an awake, spontaneously breathing infant is the gold standard for diagnosing laryngomalacia. It allows direct, real-time visualization of the dynamic collapse of the supraglottic structures during inspiration, which is the defining feature of the condition. Typical findings include an omega-shaped collapsible epiglottis, arytenoid cartilages that are medially displaced during inspiration, and a glottic opening that narrows due to supraglottic collapse. Other tests, such as a barium swallow or pH probe study, may be used to evaluate for associated gastroesophageal reflux or dysphagia, but they do not establish the primary diagnosis. Question 5. Classification. An infant presents with mild inspiratory stridor, but has no history of cyanosis, no feeding difficulties, and is following the growth curve perfectly along the 50th percentile. Based on the clinical presentation, how would you classify the severity of this infant's laryngomalacia? Option A, asymptomatic. Option B, mild. Option C, moderate. Option D, severe. The correct answer is option B, mild laryngomalacia. Mild laryngomalacia is defined by isolated inspiratory stridor without feeding difficulties, no respiratory distress, no retractions, and normal growth. Moderate cases present with stridor accompanied by feeding difficulties, associated gastroesophageal reflux disease, mild retractions, or intermittent respiratory distress, and these infants are at risk of poor weight gain. Severe cases involve life-threatening symptoms such as cyanosis, apnea, failure to thrive, or even cor pulmonale due to chronic hypoxia. Importantly, over 90% of cases are mild and resolve completely without any surgical intervention, which is reassuring to share with anxious parents. Question 6. Differential diagnosis. A 6-month-old presents with stridor that is both inspiratory and expiratory, also called biphasic. The noise has been present since birth, but is getting louder. The presence of biphasic stridor should prompt the clinician to prioritize which differential diagnosis over simple laryngomalacia. Option A, spasmodic croup. Option B, retropharyngeal abscess. Option C, adenotonsillar hypertrophy. Option D, subglottic stenosis. The correct answer is option D, subglottic stenosis. The timing of stridor in the respiratory cycle is a powerful clue to the location of airway obstruction. Inspiratory stridor usually indicates a supraglottic lesion, such as laryngomalacia. Biphasic stridor, occurring during both inspiration and expiration, suggests a fixed or dynamic obstruction at the level of the glottis or subglottis, such as subglottic stenosis, vocal cord paralysis, or a fixed laryngeal lesion. Expiratory stridor, often perceived as wheezing, typically points to lower airway issues, such as asthma, bronchiolitis, or a mobile foreign body. Recognizing this pattern guides the next diagnostic steps and the urgency of referral. Question 7. Management of mild to moderate disease. You have diagnosed a 3-month-old with mild laryngomalacia. The parents are anxious about the noisy breathing and want to know the next steps. What is the most appropriate initial management for an infant with mild laryngomalacia? Option A, observation and parental reassurance. Option B, immediate referral for supraglottoplasty. Option C, initiation of high-dose oral corticosteroids. Option D, continuous pulse oximetry monitoring at home. The correct answer is option A, observation and parental reassurance. For mild cases, the mainstay of treatment is observation and reassurance because most cases resolve spontaneously as the larynx matures and the cartilages stiffen with age. Key management steps include monitoring weight to ensure adequate growth, treating gastroesophageal reflux disease if present using lifestyle measures or medications, and educating parents about red flag symptoms that require prompt medical attention, such as cyanosis, apnea, or feeding refusal. Regular follow-up visits are essential to reassess symptoms and growth over time. Surgery and corticosteroids are not indicated in mild disease. Question 8. Management of severe disease. A 4-month-old with laryngomalacia is now showing significant subcostal retractions, poor weight gain with falling off the growth curve, and occasional episodes of cyanosis during feeding. Which of the following is the definitive surgical treatment for severe symptomatic laryngomalacia? Option A, tracheostomy. Option B, supraglottoplasty. Option C, laryngotracheal reconstruction. Option B, adenotonsillectomy. The correct answer is option B, supraglottoplasty. Supraglottoplasty is the surgical procedure of choice for severe laryngomalacia. It involves trimming the excess aryepiglottic fold tissue or the redundant arytenoid mucosa to open the excess aryepiglottic airway and reduce the inspiratory collapse. Success rates are high, exceeding 90%, with significant improvement in respiratory effort, feeding, and weight gain. Tracheostomy is reserved for the rare cases that fail supraglottoplasty or have severe synchronous airway lesions. Laryngotracheal reconstruction is used for subglottic stenosis, and adenotonsillectomy addresses upper airway obstruction from enlarged adenoids and tonsils, neither of which is appropriate here. Question 9. Complications and associations. An infant with laryngomalacia is noted to have frequent arching of the back during feeds and occasional coughing. Which clinical condition is most frequently associated with and can exacerbate the symptoms of laryngomalacia? Option A, congenital hypothyroidism. Option B, cystic fibrosis. Option C, vitamin D deficiency, also called rickets. Option D, gastroesophageal